Hello, everyone. My name is Dr. Janae Richardson, and I'm excited to present to you today on cognitive behavioral therapy for psychosis, barriers to implementation, and proposed solutions. I'm a licensed clinical psychologist at Stanford University School of Medicine, and I work at the Inspire Clinic, where we provide services for individuals with psychosis. And there I provide individual cognitive behavioral therapy for psychosis, or CBTP, for clients. I also help to train clinicians, mental health professionals, regionally and nationally in CBTP. And I also work on the inpatient units where I provide individual and group therapy. Before I continue, I'd like to acknowledge that Stanford sits on the ancestral land of the Mwekma Ohlone tribe. This land was and continues to be of great importance to the Ohlone people. Consistent with our values of community and inclusion, we have a responsibility to acknowledge, honor, and make visible the university's relationship to Native peoples. I have no disclosures to report, and I would like to give special thanks to the Inspire Clinic Stakeholder Council for reviewing many of the slides I'll be presenting today and giving invaluable feedback. And I'd also like to acknowledge colleagues Shannon Pagden and the Inspire Clinic CBTP training team for their contributions to these slides as well. All right, so I'd like to start by talking a little bit about cognitive behavioral therapy, which is a psychological treatment that's used to treat a range of mental health conditions, including anxiety and depression. CBT explores how what we think and what we do impacts how we feel. And the CBT triangle helps clients to understand how their thoughts, feelings, and behaviors are all connected to each other and impact each other. So thoughts are what go through our minds in situations. Thoughts include automatic thoughts, which are thoughts that pop into our minds immediately in a situation. Thoughts can also include a deeper level, which are core beliefs, and these are much deeper beliefs that we have about ourselves, other people, and the world. Core beliefs include things like, I'm worthless, people cannot be trusted, the world is an unsafe place. And these core beliefs really help us to interpret what happens to us. Feelings are our emotions. They're typically summed up in one word. Examples include angry, sad, and happy. Somewhat associated to feelings are physical reactions we may have in our bodies, such as whether our hearts are speeding up, palms are sweating, and so on. And sometimes people get thoughts and emotions, thoughts and feelings confused. If it takes more than one word to describe, it's probably a thought. So some people might say something like, I feel like I'm a horrible person. That's actually a thought. The thought is, I'm a horrible person. The feeling might be sadness that's associated with that. And then behaviors are what we do, or the actions that we engage in. And so each part of the triangle, again, can influence the other part, and therapists can become a place where we intervene. And the other thing I'd like to mention is that CBT is primarily focused on the here and now, and so current problems that are occurring for an individual, but past experiences can be explored to impact how they influence an individual's thoughts. So CBT is based on a cognitive model that explores how unhelpful or inaccurate thoughts influence how we feel and how we act. So crucial to the CBT model is the understanding that it's not the situation that causes distress. Let's say it's rather how the person interprets the situation. And so let's try to illustrate this with an example. Let's say the situation is someone cuts you off in traffic. If a thought that's going through your mind is that the person is trying to ruin your day, you might understandably feel angry or frustrated, and you might respond by yelling at the person. However, let's say the situation stays the same, but what changes is your interpretation of the person's intentions. And let's say instead in this example, your interpretation is that the person is having an emergency. If that's the interpretation that you're having, you may have very different feelings. You may feel compassion instead, maybe in your body, your heart rate might slow down, you might feel calmer. And then your behaviors might be different, right? You might wish the person well instead. Okay. And so since CBT explores how what we think and what we do impact how we feel, a major goal of CBT is to identify unhelpful patterns of thoughts and behaviors. And by helpful, I mean what's consistent with a client's values or goals, unhelpful, not consistent with these things. So for example, if there's a client who would like to work on socializing more with others, but they're currently socially withdrawing, that social withdrawal or isolation would be an unhelpful behavior because it's taking them away from their goals. And so this process requires that clients are aware of their goals, both short and long term, as well as aware of some of these automatic thoughts that impact their behaviors. And so in CBT, we can help clients to change unhelpful patterns by, one, helping them to identify more balanced or more realistic thoughts, to help modify unhelpful automatic thoughts. So for example, if a client may say, I never do anything well, we may help them to modify that thought to a more balanced one, which may sound something like, I may struggle with math, but I do some things very well. And we can also change unhelpful patterns by helping clients to identify healthier behaviors for coping. And so, for example, if a client is struggling with anxiety, we can teach them healthy coping strategies such as grounding, deep breathing, and so on. And since these deeper core beliefs impact how individuals may interpret situations, in CBT, we can also work on that deeper level of beliefs as well, by helping individuals to look at past evidence and reevaluate it, practice new and healthier behaviors, as well as, really support them with coming up with new core beliefs in the here and now. Okay. So I'll shift now to talk a little bit more about what is psychosis. And so psychosis is a temporary state where an individual loses contact with reality, meaning they're having difficulty determining what's real from what isn't. And this might cause an impairment in functioning and or significant distress. And so it's important, though, to emphasize that psychosis is temporary. And so just because someone is experiencing psychosis, that doesn't mean that they will be in this state forever. Again, it has to be causing distress or impairment for it to be diagnosed, and I'll talk about that a little bit more in just a moment. Again, psychosis is an umbrella term that captures a number of different experiences where one may lose contact with reality, and that's a prominent feature. Okay, step before, I'll discuss a little bit more about that in just a moment. And so psychotic-like experiences actually are common. About 10 to 15% of the general population is actually reported hearing voices at some point. And these psychotic-like experiences exist along a continuum, as we can see here. And so on the lower end of the continuum are experiences many of us have had at some point, such as maybe hearing someone call our names when there was no one around. This experience is thought to be culturally normative. Many of us just shrug it off and go about our days. As we move along the continuum, however, someone might have an unusual experience that's more frequent, it's more distressing, that's more impairing, maybe such as being convinced that aliens are saying really awful and cruel things to them. And while we know that genetics may play a role in triggering psychosis, we also know that there are other environmental factors as well that can play a role in the development of psychosis as well, including some of the things listed here on this slide, such as stress and trauma and really stressful life experiences people may have. And one thought is that, as people experience things such as stress, it may actually move them along this continuum, maybe from the place where they're not experiencing psychosis towards more of that end where they're experiencing psychosis. And so there are a couple of takeaways from this continuum model. One is the idea that we all can experience psychosis under certain circumstances that I just described. And the idea that psychotic-like symptoms are often experienced in the general population can actually be normalizing and can help to reduce stigma for many clients. Another major takeaway is that culture plays a role in whether an experience is considered psychotic or not. And so that means it's really important for us to be aware of and curious about a client's cultural background. So psychosis can include a number of different types of symptoms, including the ones listed here: positive, negative, and cognitive symptoms. And I'll get into each of these in a little bit more detail. And so positive symptoms do not mean good. If you think about a plus sign, positive symptoms are changes in a person's thoughts, feelings, or behaviors that are added on to their typical human experience. And these can include experience such as unusual thinking, which some people may think of as delusions. Within the field of CBTP work, specifically language is really important. So unusual thinking might be one of the words you may use instead, or even suspicious thinking, suspicious thoughts. But these experiences might include mind tricks, so maybe thinking that someone might be following you, turn around and there's no one there. This can include ideas of reference, such as including experiences where you believe that something has strong personal significance for you, such as believing maybe someone is sending you secret messages through a license plate. And suspicious thoughts may include things like believing the FBI is following you. Perceptual disturbances, many people think of as hallucinations. These include a variety of different types of experiences that occur along a continuum as well. And so, for example, on the lower end of the continuum, one might hear muffled sounds as you move along the continuum, though an individual might be hearing multiple voices that say really mean and threatening things that, that causes a lot of distress. And then disorganized communication may be another example of a positive symptom where someone may really struggle with getting their point across in a way that's clear. They may also struggle with maybe rambling or maybe deviating from the topic at hand or using speech that may come across to someone else as odd. Now, negative symptoms are not bad. If you think about a minus sign, negative symptoms are emotions or behaviors that have been taken away. So things that are typically there, but the person may not be exhibiting currently. And we can think of negative symptoms in terms of the 5 A's, which you see listed here. And so asociality may show up as someone withdrawing from others or really having difficulty reading social cues. Avolition may show up as someone neglecting their personal hygiene or really having difficulty planning or carrying out activities. Anhedonia may show up as someone no longer doing hobbies or things that they enjoy doing. Affective flattening may show up as someone who has a really blank facial expression, even though we might be talking about a very exciting topic. And alogia may show up as what some people consider poverty of speech, even poverty of thought, where you might be asking the person, what did you do today? And they're just responding with one-word answers. Poverty of speech can also show up as individuals saying a bunch of words that don't necessarily meaningfully communicate information. So cognitive symptoms are also associated with psychosis as well, and may include a range of different types of experiences, such as difficulties remembering information, concentrating, organizing one's thoughts, planning, and so on. And then there are some mood symptoms that may be associated with psychosis as well. Things such as sadness, loss of interest or pleasure in doing things, for some thoughts of death, irritability, and so on. And so as I alluded to before, psychosis, again, is an umbrella term that can show up across many different diagnoses. And diagnoses are made when there's significant distress and or impairment in functioning. Now, important to mention that diagnoses do serve a function. They help clinicians to communicate to one another. However, they're not labels that are used to define a person. And so on the top left, we see primary psychotic disorders where psychosis is a prominent feature of the disorder. Top right, we have the affective psychotic disorders where there's both a mood component and psychosis as well, sort of coexisting. And then psychosis can also show up in other conditions, neurocognitive conditions, for example, such as Alzheimer's disease and traumatic brain injury. Can also show up in substance-induced psychosis as well. I'm excited to talk more now about how CBT applies to working with psychosis. And so I'll start with a little bit of a history. CBTP is not new. Actually, it was used around the 1950s by Dr. Aaron Beck, who's the father of CBT. And he used CBT to treat a veteran who was struggling with some suspicious thoughts. And it was successful. However, there were a number of things that were going on societally at the time that put CBT on the back burner. One was that antipsychotics were becoming popular. Societally, people kind of believed that talk therapies were damaging for people with psychosis, or that psychosis was somehow outside of that realm of normal psychological functioning. So what this led to was kind of a prominence of the biological and medical model being used to treat psychosis. However, as some of the limitations in antipsychotics became prevalent, and as more research was done to explore the cognitive psychology of cognitive symptoms of psychosis, this led to the development of new models of CBTP and just a reinvigoration in CBTP approach in general. And so CBTP is really similar to CBT for other conditions such as anxiety or depression. The main focus of CBTP is to decrease the distress that's associated with positive symptoms such as hallucinations or distressing thoughts. Another goal is to increase functioning. And so it's important to highlight that the goal of CBTP is not symptom reduction. So we're not trying to reduce voice hearing for individuals or suspicious beliefs, but rather to reduce the distress that's caused by those experiences, as well as to improve functioning. And so reducing distress could look like teaching clients relaxation skills, and improving functioning can look like teaching them start socializing again, obtaining a job, going to school, and so forth. And so that given that the focus of CBTP is to reduce distress and to increase functioning, we can do this in a couple of different ways. One of the things I mentioned at the very beginning is that it's the interpretation of the situation that causes the stress rather than the situation itself. And so part of the work is helping clients to check out the accuracy of the interpretation. Some clients with voices, for example, might interpret the voices to be really malicious, evil, or threatening, whereas some, other clients may have the interpretation that voices are calm and helpful. And so if clients have the interpretation of the voices being malicious, and it's causing distress, we may help them to check the accuracy of that interpretation if they're open to it. We can also help clients to reduce the stress and increase functioning by addressing some of their behaviors. And sometimes working on the behaviors might be a place that a client feels most comfortable kind of working on, at least initially, and maybe what's more accessible for the client as well. And so a behavioral approach really helps clients to become aware of behaviors that they're engaging in that might be maintaining the problem. So, for example, the client that's socially isolating, but that social isolation might actually be maintaining the anxiety and the suspicious thoughts. And so part of the work is helping them to become aware of that and help them to come up with new and healthier behaviors. There are other areas that we target in CBTP as well. That may include things such as helping clients to understand the impact of past trauma and their current functioning. Again, maybe treating anxiety and depression that occur along with psychosis. improving individuals' social skills, really expanding their coping toolkit, problem-solving skills as well as helping them to develop skills to prevent relapse of future psychotic episodes. So CBTP is a form of psychotherapy, and it can also be integrated into more frontline work. So work, for example, with many members of a multidisciplinary team, such as nurses, case managers, and so on. And there are many models in CBTP, but the first skills is one of the models that we tend to work from at the Inspire Clinic. And one of the first things we may do in this model is forming a relationship. And so this is about helping clinicians to build rapport with clients. And part of that might include helping to normalize psychotic symptoms. And I mentioned before that about 10 to 15% of the general population is heard voices. And so communicating that to some clients can be really normalized and help them to feel less alone in their experiences. Can also help them to develop shared goals at this stage. Inquiring curiously really means asking questions from a curious place, not making assumptions, or practicing some humility here. And so for someone who's hearing voices, for example, a question may be, when did the voices start? When do you notice that the voices get worse? And so on. So reviewing the information and putting it together explores how clients' past experiences might have led to the development and maintenance of some of their beliefs and behaviors. And based on this formulation that you may come up with, that might then impact some of the interventions that you may come up with alongside the client. And so in the skill development, you're helping clients to develop those skills to help them support their goals. Things like maybe learning strategies to reduce anxiety, things such as deep breathing. And then trying out the skill means that they'll practice some of these skills, maybe practicing some deep breathing outside the session out there in the real world, and then coming back to us and letting us know how it went and receiving some feedback about that. All right, I'm excited to talk a little bit more now about the CBTP research evidence. So there's been a lot of research that's been done in CBTP over the past 20 years. And I think generally speaking, the research shows that CBTP does work. One of the things that the research shows is that clients do seem to find CBTP to be helpful and acceptable. So a lot of research showing that CBTP can help to reduce positive, negative, and general symptoms. And for individuals who might be at risk of developing full psychosis, research suggests that CBTP can help to delay or prevent that transition to full psychosis, which is really important. For individuals who may not be taking antipsychotic medication or who may have medication-resistant symptoms, research has shown that CBTP can be used and, be helpful in individuals fit into these categories. And overall evidence suggests that CBTP is most effective for those at risk of developing full psychosis, those who are early in the phase of psychosis, as well as those with more stable symptoms. Okay. So given the benefit of CBTP shown through some of these research studies that I just mentioned, CBTP has actually been officially recommended as a treatment for schizophrenia spectrum disorders in many national treatment guidelines, including in the US. So we see, for example, the Schizophrenia Patient Outcomes Research Team, the American Psychiatric Association, and SAMHSA guidelines all recommend for CBTP to be offered as best practice treatment for psychosis. And we also see that these national treatment guidelines extend to other countries as well. Now, despite the benefit of CBTP shown through research studies and despite national treatment guidelines recommending that CBTP be offered to clients, the issue is that CBTP is not widely available in the US and even in Canada because we don't have enough trained mental health professionals, unfortunately, to deliver the treatment. In fact, in the US, less than 1% of the mental health workforce is trained to provide CBTP. And so what this means, unfortunately, is that there are many clients who could benefit from CBTP who often struggle to access it. This is a huge issue. And so I'd like to share my story now about how I became interested in CBTP implementation. During my third year of graduate school, I completed a practicum at New York Presbyterian Hospital in White Plains, New York, where I found myself working in an acute inpatient unit for individuals with psychotic disorders. And that is actually where I learned CBTP. And so I was running a CBTP group, and I realized quickly, this is really challenging. And so I started to wonder what other clinicians were experiencing, whether they were having some of the same difficulties. And so I started to do some research. And as I did research, I learned that CBTP is not widely available in the US. And so I became interested in exploring why. So this led me to my research question for my dissertation, which was, what are the experiences of clinicians implementing CBT for psychosis, particularly here in the United States? And so I conducted a qualitative study where I interviewed 24 clinicians across the US. And these clinicians included psychology trainees, psychologists, psychiatrists, and their experience in CBTP ranged from those who were newer to the treatment, as well as those who were more expert trainers. And so I asked them several questions about their experiences, including some of the challenges that they were experiencing. And so though research might show that a treatment is helpful in a lab setting as we see with CBT, there can be many barriers to actually trying to now implement a treatment in a routine healthcare setting. And so implementation refers to the process through which we adapt an evidence-based treatment into a healthcare setting. And so what previous research has shown is that implementation can be affected by some of these factors I have listed here: socio-political, organizational, clinician, client. And so in my study, what I found is that at the socio-political level, clinicians mention how, for example, the US's sort of cultural embrace of the medical model, even some negative views about CBTP research amongst the general public, such as those in public offices, made it difficult even for CBTP to be adopted into some settings. Sort of relatedly, even on that more legislative level, things like funding and lack of insurance reimbursement for some CBTP sessions, make it hard for CBTP to be implemented in some settings. And some societal issues such as poverty, stigma, lack of access to resources are things that can actually make it hard for clients to access treatment. And we know specifically in terms of lack of access to resources to treatment that this is particularly pronounced for individuals of color. On the organizational level, clinicians mentioned that things such as not having enough time to do sessions, space, supplies made implementation difficult, as well as not having enough training in CBTP. And even for those who were trained, many of them found that they were one of the only ones trained in their setting, and that led to feelings of isolation. Some clinicians talked about how working in settings where the medical model was prioritized and CBT was not valued kind of made the implementation of the treatment more challenging. At the clinician level, self-efficacy is one of those things that impacted CBTP implementation for some of the clinicians. And self-efficacy was impacted by a number of different factors that we see here. And I think for me personally, again, given where I started my dissertation research, one of the findings that was most interesting to me was that in my study, the clinicians that were actually likely to be the least confident in implementing CBTP were those trainees who were trying to use CBTP in an inpatient setting. And then on the client level, this refers to a clinician's judgment about whether an evidence-based treatment such as CBTP could be helpful for a client based on certain variables that are associated with the client. And so in the study, Many clinicians talked about how, for example, working with clients that were acutely psychotic and really distressed, it was hard to use CBTP with individuals presenting in that way, or working with folks really deeply entrenched suspicious beliefs were challenging. In addition, working with folks with psychosis as well as other conditions that coexisted, whether trauma and substance use, was particularly challenging. And then difficulties with engagement included a range of different types of challenges as well, whether it was young clients being forced to come to therapy by their parents, clients who weren't involuntary, while in a hospital and didn't want to engage, or really clients who had been mistreated by the mental health system for so long and really kind of struggled to trust providers. And so I found many barriers and many challenges with this research, but the main takeaway isn't that there's too many barriers, there's nothing that we can do about it. So I want to shift now to talk about what maybe some of the solutions for improving CBTP implementation might be. And some of the solutions I'll offer is solutions that came from the research that I did, as well as some solutions proposed more recently by SAMHSA in 2021. And so since negative attitudes about psychosis still do pervade US culture, one particular solution might be to try to disseminate more non-stigmatizing education about psychosis to those who might be policymakers, for example. And really and truly what we want to communicate here is the message that recovery is possible for people with psychosis, as well as tying back to the research evidence that I mentioned, that CBTP is effective. So we want to get this message out there. It's really important as well for mental health advocacy organizations to partner up. So organizations like the National Alliance of Mental Illness, or NAMI, to really get more information about CBTP out there, as well as using their platform to really advocate for better CBTP access for clients. One of the things that we know is that few graduate schools at this time offer CBTP training or exposure for graduate students, and this needs to change. And so one of the things that needs to happen is more graduate schools need to include CBTP training into their curriculum. And perhaps one of the ways that these programs can help students to get more experience working with psychosis might be for those practicum sites that do offer CBTP training to partner up with some of these graduate programs. And this is really important because if graduate students are exposed to working with psychosis sooner, this can actually maybe lead to more interest in CBTP and perhaps more CBTP practitioners, which we desperately need. We know that we need more trainings and workshops for clinicians as well. We also need to lobby at the legislative level, and this is where including key stakeholders is really important. We know that funding is an issue for mental health services in general, especially for individuals with psychosis. And so whether it's advocating for more funding, advocating that funding is used appropriately for psychosis programs and treatment, as well as really advocating that insurance will reimburse CBTP sessions, because there have been a lot of issues in this area for quite some time, leading to some access issues, unfortunately. Some other solutions include, for example, forming regional evidence-based treatment advisory boards, and this can include stakeholders from different organizations in a particular region who, being committed to the implementation of CBTP in that region, might meet and share resources with each other about how to improve CBTP access for clients. And so important for them to be connected with individuals in settings where clients with psychosis are likely to present, including correctional, forensic, and primary care settings. Step care model potentially could help with the improve the implementation of CBTP. And so the idea behind step care is that if we're able to train more frontline staff in a healthcare setting, so again, people like case managers, nurses who are more likely to come in contact with clients with psychosis, we can train them in some of the basic CBTP skills, such as providing psychoeducation, teaching them some coping skills to reduce the stress and so on, that we can actually reach a lot more clients with psychosis. And so in the step care model, you would have maybe clients with psychosis, but less severe symptoms, maybe accessing this kind of lower intensity CBT-informed treatment from maybe members of the treatment team, such as a case manager or so on. And then for individuals who might have more severe symptoms and maybe require more specialized treatment, maybe those might be the individuals that see clinicians with the more specialized training. And I think related to this piece that I'm bringing up now is really us thinking about how we can leverage the use of technology. And so with more clients with psychosis having smartphones today, it's really important for us to continue to think about and explore how CBTP-informed skills, for example, can be offered to clients through this modality of mobile phones, for example.